First of all, I want to appreciate President Harap for giving us very precious opportunity. Our society CSRS AP was founded in 2010 as a sister society of CSRS and CSRS European section. As we are the youngest society, we have been struggling to catch up even a little in the history of about 12 years. As you know, more than 60% of the world population lives in Asia-Pacific region, and many patients are suffering from cervical spine diseases. Among them, there are many intractable cases involved. Today, we want to introduce 5 categories of intractable cervical disorder we have confronted in Asian countries. Our education committee selected 5 surgeons who are leaders to treat them in each country. First topic is infectious diseases in cervical spine, presented by Dr. Rajasekaran from India. Second is severe deformity explained by Dr. Suk from South Korea. Third topic is hyperkinetic cervical spine, mainly in athetoid cerebral palsy patients. I am in charge of this topic. Next intractable disorder is drop head syndrome. As the aging society advanced, this disease is increasing in Asian countries, including Japan. Then Dr. Ishii will present it. Last topic is tumors, including of metastasis at cervical spine. China, the world's most populous country, is actively working to treat very difficult tumors in cervical spine. Dr. Feng Wei from China is a speaker of this topic. As you know, cervical spine locates between head and heart and play an important role as a human lifeline. Therefore, we cannot run away from intractable cervical disorders. That is the reason I pick up them of CSRS AP 2023 as cervical spine between head and heart. If you are interested in our struggles and experience, please join our meeting in Yokohama, Japan. The third topic is hyperkinetic cervical spine at the CP. I will give a lecture. I want to appreciate President Harop and organizing committee of CSRS 2022. My name is Hisanori Mihara. It's a great honor for me to give a lecture entitled How to Treat Hyperkinetic Cervical Spine. One of the characteristics of athetoid CP patient must be hyperkinesis of the neck. Their cervical spine has been exposed to excessive involuntary motion for many years. Such overstress may cause cervical deformity and develop the neural symptoms as a secondary disorder. To consider the pathological features of CP cervical, failure of anterior column causes vertebral deformity and multiple disc collapse, which induce multidirectional instability. Then all 3 columns show deformity and finally advance to 3D malalignment. We have performed surgical treatment for 245 patients in about 40 years. Most cases showed subaxial lesions and mainly underwent front-back fusion. 20 years ago, several papers introduced satisfactory results with laminoplasty combined with muscle release. We believed these reports and adopted laminoplasty in selected patients. However, opened lamina could not withstand their hyperneck motion. 2 of them required early revision surgery because of neurological deterioration due to spacer dislodge and laminar fracture. Then we decided to exclude laminoplasty for CP patients. Through such experience, we decided to perform circumferential fixation for CP patients. On the anterior, segmental fixation might be most stable. Keep the facet and lamina for fusion bed in middle, and fix the posterior element using the spinous processes. Even if a patient shows severe deformity, We can achieve realignment using interspinous device named wavy rod. After position change, HCDF can provide additional correction from anterior. During 40 years, instrumentation has changed over time. In the first cities, we used screw and wire technique, with which we experienced 8.8% of reoperation. This 48-year-old man with kyphotic deformity underwent C37 front-back fixation. 2 weeks later, anterior graft was collapsed and C3 spinous process was broken. This case required a salvage surgery, but the alignment remained kyphotic. Then we started to use rigid plate for anterior reconstruction and stronger rod system for posterior fixation. However, the reoperation rate was rather increased to 14% by this alteration. Many of them showed instrument failure, including breakage of locking system like this case. So screw-related instrument failure occurred more frequently, although the system changed to rigid types. We learned rigid system was inadequate for hyperkinetic spine and changed the plate system to dynamic or semi-constrained type. Then the reoperation rate had successfully decreased. Semi-rigid plate system may allow some degree of subsidence of the graft, like a soft landing. Our interspinous fixation is also semi-rigid system. I believe combination of soft fixation from anterior and from posterior may contribute this improvement. This is the real spirit of judo. Ju means soft, the do means way in Japanese. So judo means soft way. Don't use strong force, the soft way is how to get along with enemy. Acetoid CP patients sometimes show upper cervical regions. Our first choice for craniocervical instability was OC2 or OC3 posterior fixation. However, as many of them combine with lower cervical regions, we often worry about range of fixation. In this case, we selected OC2 posterior fusion and C3-5 front-back fusion, so C2-3 was left as floating segment. Fortunately, this case maintained good stability as the C2-3 mobile segment until now. Why we kept the segment to be mobile? Because we experienced very high rate of instrument failure after total fusion from occiput to lower cervical spine. Of course, we should pay careful attention on the mobile segment. We kept OC1 and C23 to be mobile in this case. Then the tip of the rod migrated into the occipital bone, causing pain and disgusting sound for 1 year. Although we encountered various difficulties, we could obtain acceptable neurological improvement and was maintained as a final follow-up. But OC fusion cases indicated a significantly lower recovery rate, probably because of delayed diagnosis of myelopathy and higher rate of instrument failure. I need to inform you that we have experienced milling reoperation in 40 years. Several patients were required 3 times or more salvage. The total reoperation reached to 72 times. As I introduced, early reoperation can be prevented recently, but the late reoperation has not decreased. Rather, it is increasing as the follow-up period becomes longer. One cause was adjacent segment disorder. This case developed lower adjacent segment instability 4 years after C3-6 front-back fusion. Another cause was craniocervical instability. This 73-year-old woman recurred myelopathy due to atlantoaxial subluxation 25 years after initial surgery. She required OC3 fusion as a late reoperation. How can we prevent such late reoperation? When looking at the alignment of huge segment, there was very clear tendency that almost all patients who required late reoperation had shown kyphotic alignment of the segments. We learned that kyphosis may increase the risk of reoperation due to ASD or CC instability. When checking the timing of late reoperation, adjacent segment disorder developed earlier than craniocervical instability, but both pathologies usually take long time. So we should prepare lifelong relationship with our patient. At the end of my lecture, I want to thank my patient for giving me precious experience and valuable lessons. Thank you for your attention. Okay, so as you know, in the US or European countries, so they don't have enough experience of CP patient, but most of them require surgical treatment when they develop the secondary disorder. So please challenge this pathology. Thank you. Okay. So I have one message. So when we confront the very tough case, we should observe and take very carefully examine the patient neurological condition. And after that, when we perform the surgery, we should keep original structures as much as possible and make reconstruction using such original structures. That is my most important message to you. So thank you for listening this session. So we enjoyed discussion. Thank you. Thank you, the lecturers. Thank you all.
Thank you very much.
Thank you.